Optometry. I'm Dr. Jacob Lang, and welcome to another episode of the Mod Pod. I'd like to welcome you back to the third installment of Empower 2026, where we aim to help advance optometric knowledge and elevate our patient care. Today's episode is going to focus on the latest, the greatest, the newest in ocular surface disease, something I see a lot of and I'm very passionate about. I'm joined by some, great friends and colleagues, Dr. Mark Dunbar and Dr. Josh Davidson. Thank you, gentlemen, for joining me this evening. Want to introduce yourselves briefly, and then we'll dive into it.
Awesome. Thanks, Dr. Lang. I'm Josh Davidson. I'm an optometrist down here in Baton Rouge. I'm a native of Michigan, but moved to the South. And I run our dry eye center at a large surgical practice called Williamson Eye Center. We've got 9 clinics. And I get all the fun stuff that the other ODs and MDs don't want to handle. So busy stuff. I've got a couple different companies out there in the dry eye field. So my life is dry eyes. So I'm really honored to be here.
Yeah, that's great. And it does feel like that sometimes that, if you're a dry eye specialist, you get all the things no one else wants to deal with. We are sometimes the unsung hero of the clinic, in my opinion, but of course I'm biased as well.
My name is Mark Dunbar. I practice at the Bascom Palmer Eye Institute in Miami, Florida, where I have been for a career over 35 years. I do primarily comprehensive optometry, so I do see a ton of dry eye as well as a ton of everything else that kind of falls into comprehensive eye care, glaucoma, cataracts, diabetes, AMD, the list goes on. So, my perspective, I was lecturing for Allergan when Restasis came out. And so, I've got 20 plus years, I don't know how long it's been, 2002 or 3 since, Restasis. And for a long time, that was the only one. So it's been great to see the dry eye journey. It's been great to see optometry really becoming the owner of dry eye and ocular surface disease as we should. And you look at the number of prescribers. I'm very proud of our profession for really stepping up and really taking on the burden of this disease that we see every single day in our practices.
Let's stay there for a minute. Like, we really have kind of taken this on, and now you're seeing young grads, young students, which you both work with all the time, coming out, like seeing this as commonplace to prescribe medications for ocular surface disease for dry eye. But it wasn't always like that. And we weren't always the most common prescribers of that. So Mark, let's talk about that a little more. We had Restasis, and then the Fitogras, kind of the next one, Xiidra, the next one, which was, how long ago now was that?
I don't know. I mean, but remember, it took 10 years or maybe 15 years between getting Restasis and Xiidra, the Fitogras. So, I think we, as optometrists, we would maybe write for an antibiotic. There was a lot of fear around steroids, so there weren't a lot of opportunities around treating ocular surface disease. And so you look at where we are today, and really some of the things we're going to talk about, having to go through specialty pharmacies, which, that in and of itself, if you're not a prescriber, can be a little bit intimidating. And I hope we get a chance to address that, because that's not a big burden to get over. But you're right. It's just been amazing to see optometry embrace and become, more prescribers for ocular surface disease. And I think it's because we have so many choices, and, people like yourselves, and, we've grown up around, mentors who were prescribing and treating, and of course, success breeds success. So you treat a few and patients do well, it inspires you to do more. So I think it's been great to see and watch.
I want to kind of chip in there. I think what Dr. Lang said earlier was very true. It seems like optometry really has embraced this. And I think all of us here do have students. We don't have a resident, but we have ophthalmology fellows and optometry students. And the optometry students are excited about treating dry eyes. They're excited about looking at all these new medications and how they can kind of create their own little algorithm. And just in the last couple of years, we have seen our students have a lot more interest in dry eye. Before it was glaucoma, refractive surgery management. Now everyone's excited about dry eyes.
That's great. And I think that speaks to having more options, having a better understanding of this, realizing, like, to your point, Mark, like, we can do this, and we can control this and we can manage this and we can make patients' lives better. So we started with a couple anti-inflammatories with Restasis and Xiidra. And kind of like you mentioned, Mark, before that, steroids. And still steroids are a big part of my practice and all of our practice. And I think that using the anti-inflammatories has probably given us more confidence in managing inflammation, and maybe given us more confidence in using steroids and really thinking about inflammation first. Where do you see this inflammation journey going?
Well, we do know that, and correct me if I'm wrong, that I think we just have a new approval, or we're about to get a new approval for a steroid. So I do think that we're going to really be discussing it more. But in my clinic, I see a lot of opportunity for anti-inflammatory use, whether that's something like Isuvas, which is lodiprednol, just in a slow or a smaller molecule. I use that quite often for my patients that are having those flare-ups. Those patients that maybe don't have dry eyes every single day, but 2, 3, 4 times a year, they have a really bad flare-up, and the only thing that really gets them down and comfortable is a steroid. I really do enjoy all the cyclosporins. I know it seems like there's a new one coming out every 6 months, but man, I'm a huge fan of cyclosporin, and Xiidra has been one that I have used a lot.
I think all ocular surface disease, particularly dry eye, have an inflammatory component, so I think we've all recognized inflammation being a key driver. So whether you're gonna, if it's the dry eye isn't bad enough, so to speak, you'll start with the traditional cyclosporin or a Xiidra. But I think we've all done combination of using a topical steroid and one of those anti-inflammatory cyclosporin Xiidra drops, and they're hugely successful. Even if it's MGD, if it's there's a number of ocular surface conditions where inflammation is really a key driver, and I think you have to address it.
Yeah, let's stay on this for a little bit more, but you definitely led me down in the next path. Vivi is probably the newest anti-inflammatory, being cyclosporin as its active ingredient. How have you guys seen that in your clinics? Where are you using it? What do you find that's different, or is it just another cyclosporin?
I love Vivi. I will tell you my go-to is probably a Restasis, generic Restasis, and not because I think it's better. I think it's just access, especially South Florida, Miami-Dade County. Patients can get it. They need to be on an anti-inflammatory dry eye therapy. Personally, I don't think there's a marginal difference between a cyclosporin and a lifitegrast. I think they all do very similar. We can argue lifitegrast works a little bit quicker, but I think they're all 2 to 3, 4 weeks. You should be getting a therapeutic benefit. So Restasis, generic Restasis is my go-to because I know patients can get it. And the caveat is that's changed within the last couple of months. So my other really favorite is Vivi because I like what the company has done. I like the formulation. It's formulated like Meibo. It's, if nothing else, patients are going to pay no more than $59. I think that's a win for a branded medication. So that really, for me, if I had a first choice, it would be that.
2 thoughts. How do we say it? Is it Vivi or Vivi? Has anyone decided that?
I'm up in the north, so we have to use all our vowels and pronunciate them to the nth degree. So I always say Vivi, but I don't think it, just.
And I universally pronounce everything wrong, so I couldn't tell you.
Dr. Dunbar, I think I completely agree with you about Vivi. And in that cyclosporin kind of family, I kind of think of it like that jersey behind you. It's a Tyreek Hill. Tyreek Hill, what is he? He's small and fast. And I do find that, of course, we know Vivi it's a smaller drop. That's why the bottle size, you've got to have that discussion with your patients that, hey, I know it's a small bottle. The drops are a lot smaller. So it's kind of small like Tyreek Hill. And I do find just clinically that it does work faster than Restasis. So it's small and fast, kind of like Tyreek Hill back there.
It's been a great addition. I think, they've done some really great things with the vehicle being a semi-fluorinated alkane. I'm not going to get into my organic chemistry too much here, but using a semi-fluorinated alkane more as a way of delivering drug. And we'll talk about the other semi-fluorinated alkane next, but a way of delivering drug with less side effects, less burn and sting. But I agree. I think it's been stronger. I found, in my clinical experience, I found Xiidra stronger than Restasis. I find Vivi stronger than generic cyclosporin. So I definitely feel like that's there. But they did kind of keep the burn and sting down in a way. And then to your point, Mark, the access. Harrow seems to be a company that's really focused on access and willing to put their money where their mouth is, so to speak, and saying we're going to get this to patients. So let's move on to other semifluorinated alkanes. We have Meibo. Meibo is a semifluorinated alkane derived to prevent evaporation, to stick on the eye longer, not necessarily as a vehicle for drug, but a way of just locking in the moisture and lubricating the ocular surface. Where are you guys using Meibo, or when are you reaching for this, and how have you found Meibo fitting into your complicated ocular surface disease clinic?
Honestly, Meibo is kind of my fave. I really, really enjoy Meibo. We kind of joke around clinic that, oh yeah, if you have any, if you don't know what's going on, throw Meibo on it. It works so well. For those patients that are in front of their computers for long periods of time. We know patients are blinking a whole lot less when they're in front of technology. And of course, it's the blink that's pumping that Meibum out. And if they are not pumping the Meibum out, this is a great way to kind of replace that. And actually, what's interesting is when you actually look at the Meibo studies and their slide decks, the perfluorohexyloctane was actually found on I think it was a bench study, to be more effective than normal Meibo or human Meibum, which still is amazing to me. And I found a lot of really cool kind of, I would say, off-label uses of it. But for my patients with nocturnal lagophthalmus, this works incredibly well. Just because you're forming that nice barrier on the front surface, it's been kind of one of our go-tos. And also what's really interesting is how fast Meibo works. Also in all their studies, we see it works in as little as 5 minutes, reducing pretty much every ocular surface symptom. So it's fast. And patients cannot really complain about it burning because there's no water in it. There's no pH. It's one ingredient. There's no preservatives. There's no steroids in it. It's very smooth.
Yeah, well said. I mean, I agree 100%. I love it too. The biggest issue is access. And as time goes on, I think that's gotten better and better. This is a drug where, if you want patients to get it, you have to use a specialty pharmacy. I typically use Blink, but, I would say, my ability to get it in patients' hands was about 30%. I would be curious what you guys say. The folks at B&L tell me that it's gotten better in access. I have no doubt about that. It does seem like patients are able to get it more, but yeah, I mean, it is the go-to drug, as we know that, evaporative dry eye is probably one of the most common. It's a key one. It's been a void in terms of our treatment armamentarium. So to have that is great. I'm lucky enough. I have a lot of, Central South Americans, but a lot of Europeans. And as you all know, it's available over the counter in Europe as Evo tiers. And so I have a lot of patients who, if they can't get it through the insurance, they're getting it from family members or traveling, to Europe. And I think it really has been a very, very good additive to our dry eye therapy.
I do want to add one more, and those are all great points. I do want to add one thing about Meibo that maybe some of the audience hasn't really thought about. Williamson were a really big refractive surgery practice. And what I find is that Meibo works really well for our LASIK post-ops. Again, we know that it's got a longer residence factor than any artificial tear out there. And when you optimize that front surface of the eye, boy, oh boy, I clinically find that a lot of my patients notice sharper vision. Same thing with premium multifocal IOLs in their post-op period. So I go to that really quickly if the insurance covers it.
Yeah, it is definitely one where it's more successful in commercial patients where we can kind of control access a little bit more. It's been tougher access with my Medicare patients, but I've been seeing the Bausch Lomb rep lately. Optimistic that Bausch Lomb is, they're obviously working very hard to own ocular surface disease. Whether you talk about measuring osmolarity, Xiidra, Meibo, pipeline, they're definitely working hard, and part of working hard as a pharmaceutical company is making sure patients can get it. So it's be interesting to see how that evolves but it does have that instant gratification that you guys both spoke to, and that seems to resonate with patients.
It is a small drop. It's a small bottle. It is a small drop. It is a unique formulation. We've never seen a molecule or a drop like that because, as you said, it's not a water, it's not an oil, there's no pH, it's comfortable. So I think just letting patients know what to expect is really important.
Yeah, for sure. Yeah, small drop. You don't feel it when it goes in. All the patients tell me silky. But I tell them it's going to be different. Dripping, it's going to be different. Be prepared for that.
Tarsus Pharmaceuticals Incorporated applies proven science and new technology to revolutionize treatment for patients across several therapeutic categories, starting with eye care. Their lead product, Xdemvy, lotilaner ophthalmic solution 0.25%, is FDA approved in the United States for the treatment of Demodex blepharitis. Learn more at tarsusrx.com.
What do you guys think about, we've, focusing on like saying evaporation and maybe thinking more about Meibom. What do you guys think about this percentage wise? Like, what do you think the percentage of like MGD versus aqueous deficiency is, and what percent of the population with dry eye falls somewhere in between that have a little bit of both? So Josh, I'm going to ask you this question, this spectrum of disease, whether MGD on one side of the spectrum, AQD or aqueous deficiency on the other end of the spectrum with regards to where do most of your patients fall? Where are they at? Where are they in regards to this data about, certain percentages here and there?
I don't know about the percentages as far as, what my clinic is and what my patients are, but I would say overwhelmingly it's mixed. It's evaporative with a little bit of aqueous. Whether that aqueous reduction is from inflammation on the ocular surface. But yeah, I would say in my clinic, primarily mixed, which, in my clinic, I do really well as long as there's no ocular rosacea with regular heat therapy, whether that's the Bruder mask, the disposables, whatever it may be, and then some kind of immunomodulator or steroid for flare-ups. That's kind of my basic fastball, if you will. We all in all of our clinics, if you're listening to this and you got dry eyes and it's kind of a run-of-the-mill dry eye case, or for us at Williamson, run-of-the-mill cataract surgery, you should kind of have your fastball, your algorithm that you're pretty comfortable with or most comfortable with for most of your patients. And my fastball is that, regular use of heat and then some kind of anti-inflammatory. So again, mainly mixed.
And that's kind of how I live my treatments, is saying you have a little bit of both, but this might be worse than that, or I want to tackle MGD first over aqueous deficiency. And actually, I have a lot of older patients that are kind of more end stage ocular surface disease just because of my clinic and I think my setting. And so I actually feel like I see a lot more aqueous deficiency than a lot of my colleagues. And that's the one thing they haven't treated. They've been aggressive with, focusing on MGD, that maybe our education has done too good of a job to tell everyone to look at the lids, but they're not looking at maybe the tear meniscus height or some of the other things we'll see in aqueous deficiency, or that they only got so far and then they stopped and didn't treat the aqueous deficiency. And that's what got the patient across the finish line when really trying to maximize their ocular surface.
You look at a younger patient and no question, you think more of an MGD component. And that's why, Meibo works so well. In an elderly, you think more combination. And, I think ocular surface dry is a little bit like glaucoma. You try to keep it simple. And if you can treat it with one drug, and again, I think inflammation is always a key driver, which is why that's usually our first go-to, is trying to treat inflammation. And then either adding on a drug like Meibo, or if you're lucky enough, if you've got meibography and you can look and you see a lot of Meibomian gland dropout, then it makes sense to maybe target the that evaporation first. But certainly there are a good percentage that need to be on both. I have no problems having patients on both, but I like to try to keep it simple.
And we've expanded into neuromodulation, right? We were using the nervous system to activate tear production. We had Tyrvaya as our nasal spray to stimulate nerves and activate the lacrimal functional unit. And now we have Tripteer. TRPTIR is this cool receptor, TRPM8 stimulator that activates the corneal nerves to stimulate tear production by activating those corneal nerves. And we all know that your cornea has 400 times more nerve endings. So why not use it as a target for neuromodulation? Where do you see, how have you seen neuromodulation, especially our newest weapon, TRPTIR? How have you seen that working in your clinics? How has the response been?
I haven't had much experience with it. It is relatively new. I think in Florida, it's not been available to us for that long. I've been really intimidated by the side effect profile, the redness, the irritation, and whatnot. And then again, just because of the unique environment, patients in Florida or South Florida anyway, access becoming a key driver. So it's certainly not a first choice or maybe even a second choice. I hope to use it more, but that's really been the limitation is, the redness and irritation and burning that patients, especially the burning. I'm not sure how to get past that. I would love to hear your all's response of what you think about it.
Yeah, I think let's focus on that. So that's about the biggest thing I think we see in their adverse event, or if you want to call it side effect profile, is about 50% of patients are going to notice installation site pain. Tends to be kind of a burning sensation for about 30 seconds to a minute. How have you seen that in your clinic, Josh?
So I'm a huge, huge fan of TRPTIR. I actually take it personally. And I think it's really exciting. So again, like you mentioned, we know the cornea is the most nerve innervated part of the body. And yeah, like Dr. Dunbar mentioned, and like you mentioned, Dr. Lang, that the side effect profile is big. And the only side effect that I really hear about is the burning. And when I explain to patients, hey, this is going to work on these cold receptors, and I actually went through it probably twice today, how it's going to kind of work. One of which was an engineer patient. So he really wanted to know. Yeah. And it makes sense. And if you kind of prime that patient for the burning, I mean, a lot of these drops burn. Xiidra burns sometimes in our patients. So Restasis did for a lot of our patients. So we're used to kind of letting patients know, hey, this is probably going to burn. And it's just a quick burn. And then afterwards, a lot of our patients feel great. I think it's like 48% of patients on day one with TRPTIR notice an improvement. I mean, that's mind blowing. So it's a huge part of my clinic. I just prep them. I say, hey, it's going to burn, but this is really one of the stronger ones we have out here. It's a completely different mechanism of action that we haven't tried yet. Let's give it a shot.
Yeah, I like that. We talked about fast earlier when we were talking about Meibo. And I think this, again, is one of these fast things. That's the good thing about nerves is they do things fast. So you have that kind of instant gratification of they are going to make tears right there, right then when they put that drop in. But yes, the other thing I kind of explain to patients is it's working on nerves. And so you're going to feel it, right? Like if you're not feeling it, I actually have a patient coming back because she's like, yeah, I feel like, I think I'm doing better, but I don't feel this at all. When she puts it in, she's like, I don't feel it at all. And I'm like, nothing? Like, feel it hit your eye or kind of a cool mentholy feeling? And she's like, nothing. So I actually have her coming back to do like some corneal nerve testing because I'm just curious why she doesn't have that. And maybe she's just that sort of patient where she doesn't, or maybe there's something going on. I haven't figured it out. But I warn my patients and I just tell them to assume they're going to feel something and that it's because it's affecting nerves. And they seem to get that. And I've had a few, but I can't say I've had many patients stop using it. I actually have some patients that say they like the burn, like they like how it feels. So it really seems to have some power in tear production. It's got that quick response. I think Alcon has done a great job with trying to get it in patients' hands so they can test drive it, get a month free, see how it's going. I've had a lot of patients coming back in that 3 to 6 month period where they're like, I'm getting better yet. And that's been really exciting in my clinic where they're saying, I'm getting better yet. Like I can tell this is making me better yet. I'm making more tears than I was 2 months ago. So it's been a good tool. I think it has some nuance to it in that mechanism of action. that we'll have to warn patients about, but it seems to really have some power in activating the lacrimal functional unit. And it's not just water. I think they did a great job of doing that phase 4B trial, looking at the lipid concentrations after instillation and actually seeing that the lipid concentrations went up, that the patients were making more oil after instilling it, not just water. So saying we're targeting both oil and water, and talking about, on the spectrum, maybe we're activating more of that mixed thing and saying patients that need more tears, and how can we make that happen? So we'll wrap it up here in a minute or two, but there's a couple things I wanted to touch on that aren't FDA approved. One of them's Azura.
I have sat on a couple board meetings with them, and I think it's an exciting potential of an eye drop.
What's it do?
It apparently, the meibomian glands, we know they produce meibum, and they almost always over time will kind of create a little cap on it, if you will. And so this is essentially a unique formulation of Selsun Blue that is a I want to say keratolytic. That's not the right verbiage, but it's it's not an everyday use, but it really essentially dissolves or uncaps the tip of the meibomian gland, or the top of the meibomian gland, to allow the meibum to be able to be released. And so you look at the data and the mechanism of action. I think it's going to be another kind of an important drug in our armament of treating MGD. So
yeah, we'll see once the data's out and once it's FDA approved, but it sounds like it's kind of softening the meibums, or maybe making them more oil-like and less butter-like, and getting that out of there. I don't know about shampoos. I have a hairstyle that does not lend itself to many product usage, so it kind of lost me for a minute there, but no, it'll be great, and it's a good one. The other big one is a company, Ocular, that's trying to target neuropathic eye pain, which has been really, such a horrible condition for patients. Of course, they have pain that just won't subside, but also for doctors, or at least eye doctors, saying, I really can't help you. I don't have a tool to help you.
The neuropathic is tough. That is tough for doctors, for patients, for staff. Those are just depressing cases, because what that is basically, obviously, the opposite of neurotrophic. Neurotrophic, they're staining with no pain. These are these patients that have a ton of pain. They're very, very uncomfortable. And when we look at their eyes, they look pretty darn good. These symptoms just don't match up with the signs. And what Okio seems to be doing is, from my understanding, I had a call last week with some of their team, that it's going to be a novel molecule that potentially they use for up to like 3 months at a time. So we're still kind of learning more about that. I think they just enrolled, or are in the process of enrolling, phase 3. But this would be, I don't like the term game changer. I really, really don't. But just like Oxervate was pretty much a game changer in the neurotrophic area, Okios could very well be a game changer in the neuropathic. So again, this would be a drop that we would expect to kind of dull the pain and maybe kind of quiet those nerves down.
Yeah, it'd be something that we haven't had, and something that a lot of patients have been asking for. So I think that's exciting. I think kind of what we've hit on tonight has been, there's a lot of opportunity for improving our patients' ocular health. There's a lot of different things that we can do to help their ocular health. And I don't think, there hasn't been a silver bullet. There probably never will be a silver bullet for this condition, but it's important to acknowledge the patient's signs and symptoms. It's important for optometry to treat these patients and prescribe medications and prescribe therapies and do procedures to help these patients do better. So I'm going to finish with kind of wrapping up. If you had, one thing you'd recommend to our colleagues that maybe they're dabbling in ocular surface disease, and they do a little bit of this and a little bit of that, if there's one tip that you found really successful in your clinics, what would be the one thing you'd recommend or have as a tip for our colleagues that are dabbling with all these new innovations coming out?
We've overcomplicated dry eye ocular surface disease, and be it all these technologies, whether it's osmolarity or inflammodry. I mean, all these things in Meibomian gland, imaging. I mean, there's people who've obviously specialized it and have done very, very well. But if you're in the trenches, don't let that stuff overcomplicate you. Listen to your patients. We know that many of them come in with classic dry eye symptoms. Treat it. It's important for optometry. And I believe that, you're not going to win every time, but start. And if this doesn't work, you've got other tools in the toolbox to try to manage it and treat it, but keep these patients in your practice. Let optometry really continue to own this disease and manage it.
Beautiful. Beautiful. Josh?
Snaps. I couldn't put that any better than Dr. Dunbar, but I want to emphasize one thing he said was that listen to your patients. If you listen to your patients, you're going to learn a lot. If they wake up in the morning and their eyes are red and irritated, well, that's going to guide you down this one road. If they're in front of a computer and their eyes are getting drier and drier throughout the day, that's going to take you down another road. I have been harping on talking to your patients about getting a good night's sleep for a very long time. These common sense things that a lot of times our doctors just don't, and our colleagues just don't take the time to talk about. Creating a handout with just some, recommendations for, hey, what about a humidifier? What about getting a good night's sleep? Don't forget about your mask. But again, I think that Dr. Dunbar hit it right on the head. Listen to your patients.
Great comments from a couple great born and raised in Michigan, both of you. Now you both live, it's about far south as you can get in the United States, Louisiana and southern Florida.
There's no palm trees in Bay City, and there's no palm trees in northern Michigan either. So
yeah, I can see that the winters affected your career decisions and pathways. But no, thank you guys for such a great conversation, and thanks for spending time helping optometry. Again, I'm Dr. Jacob Lang, and thank you for listening to this special episode of the Mod Pod. Please stay tuned for another Empower installment coming your way soon.